Morning. I'm Dick Miles, Board Chair of the Foundation for Barnes-Jewish Hospital, and I'm honored to welcome you to our Legacy Circle virtual celebration. We're excited to have this opportunity to recognize you, our loyal, generous donors. Your visionary giving and partnership brings more promise and hope for the future. While we enjoy being together in person at our annual Legacy Circle luncheon, this year we're pleased to be able to celebrate your generosity more safely by offering you a virtual event. With your generous gift through your estate plan, you have made an investment in the future of healthcare that will further research, education, and advancements in treatments. For many of you, your support is both philanthropic and personal, since devastating illnesses such as cancer and heart disease affect so many of our families and friends. The Foundation for Barnes-Jewish Hospital links donors and key healthcare partners. So whether your gift is for Barnes-Jewish Hospital, Barnes-Jewish West County Hospital, Siteman Cancer Center, Goldfarb School of Nursing at Barnes-Jewish College, BJC Home Care and Hospice, Evelyn's House, or research at Washington University School of Medicine, it makes a significant impact. Today we honor and sincerely thank you for your generosity and commitment that is creating a brighter future for our community, our nation, and our world. You're an essential part of ensuring that everyone we serve now and in the future benefit from exceptional, compassionate care. Each of you makes a difference. And the research you hear about today will show what a big difference that is. At this time, I would like to introduce Susan L., Vice President and Executive Director of the Foundation for Barnes-Jewish Hospital.
Thank you, Dick, and thank you everyone for joining us today. We are very pleased to have Dr. Ron Bose as our guest speaker. Dr. Bose is a breast cancer medical oncologist and prominent researcher at Siteman Cancer Center with a special focus on HER2-positive breast cancer. Through his groundbreaking work, he sees the impact of donor gifts every day. His breast cancer research has given hope where there had been very little before. HER2 is an oncogene that plays a major role in breast, lung, stomach, and other cancers by fueling cancer growth. HER2-positive cancer is an aggressive form of cancer that has a tendency to spread and recur. It stems from a gene mutation. Dr. Bose and his team determined that genome sequencing of HER2 could detect these mutations and could help identify which drugs would be most effective based on the individual patient. This led to a clinical trial to test a drug that is now successfully used in patients with HER2-positive breast cancer. This breakthrough and others have made a dramatic difference for patients. In the 1980s, HER2-positive breast cancer had the very worst outcomes. Today, it has one of the very best outcomes for patients. Dr. Bose has played a significant role in that progress, but he's not done yet. Currently, he is conducting another study on HER2 mutations to determine how to maximize drug treatments for patients. To date, more than 40 new possible gene targets have now been identified by breast cancer genomics. Dr. Bose and his colleagues are taking these results to produce new breast cancer treatments for patients. They have also taken part in a national trial that has led to a genetic test for patients with early-stage breast cancer to predict recurrence risk as well as guides decisions about chemotherapy. This guidance, based on patients' individual genomics, has been a game changer in cancer treatment. It means thousands of patients can safely avoid chemotherapy, and it offers them a welcome sigh of relief. This is truly personalized medicine at its finest. And these are just a few examples of how donors' gifts have led to nationally recognized research at Siteman Cancer Center that has transformed the standards of care for breast cancer around the world and has saved thousands of lives. That makes every gift more meaningful, and this progress is truly inspiring and makes me so proud to be associated with this kind of work. Now, let's learn a little bit more about Dr. Bose before he takes the stage. Dr. Bose received his medical degree and his PhD at Cornell University, followed by an internship and residency right here at Washington University School of Medicine. His postgraduate training also included a fellowship in medical oncology at Johns Hopkins. In 2007, Dr. Bose returned to St. Louis, joining the team here at Siteman Cancer Center. The cancer world has taken notice of Dr. Bose's impact. In 2013, he received the Susan G. Komen Award for Health Professional of the Year and was recognized as a pink tie guy 2 years in a row. Before I turn it over to Dr. Bose for his presentation, I would like to remind you to type in your questions to the question and answer box on the right side of your screen. He will be answering your questions after the presentation. And now, just for a minute, let's pretend we're all together and welcome Dr. Bose with a big round of applause. Dr. Bose.
Hello, I'm Dr. Ron Bose, and thank you for joining us today. We're going to be talking about how we can advance breast cancer treatment using genome sequencing. Genome sequencing and DNA sequencing is a very important technology. You hear about it indirectly in the news as we're talking about the COVID pandemic. DNA sequencing has been essential to developing the vaccines that many of you have received for COVID-19 and is essential to tracking the variants, the UK variant, South African, Brazil variant, and if newer variants emerge, the DNA sequencing is picking that up. So this technology has been around for several decades, but around 2006, it went through a revolution. So now the cost to sequence a human genome is under $1,000. What you're seeing on this graph here, provided by the NIH, is a curve that the curve in white is Moore's law. It's a principle in computers and computer chips. It's made your personal computers affordable, your smartphones, and it said that the cost of a computer would fall by half every other year. And from 2001 to 2006, that's what we saw with cost of genome sequencing. But starting in 2006, a new technology became available that really brought the cost down. By 2011, it cost only $10,000 to sequence a human genome. And now with further advances, it's under $1,000. So we can use this technology for patients. And there's two categories of genes or gene changes that we look at for breast cancer patients. The first category I'm going to talk about are the inherited changes that you got from your parents. And BRCA1 and BRCA2 were the first genes that were identified for inherited forms of breast cancer. Those were identified in the early to mid-90s, and we've been testing for them since. Standard ways to treat patients with BRCA1 or BRCA2 is to either discuss prophylactic surgery, mastectomy and removal of the ovaries, or to discuss enhanced screening for breast cancer and ovarian cancer. About 8 years ago, with the advances in these genome sequencing technology, panels for additional genes came out. And these panels covered 25 to 40 genes for inherited forms of breast cancer. And I'll go into that in just a little bit. Let me touch on the non-inherited forms first on this slide, though. So we call these somatic mutations because the word somatic or soma refers to the body in Greek. These are mutations that are found just in the cancer cells. They're not in the rest of the cells of your body. They're not passed on in the sperm or egg. And there are many types of somatic mutations in cancers. Some examples are oncogenes are turned on in cancer, whereas tumor suppressor genes are turned off. Their normal function is to suppress cancer growth, but when they're lost, the cancer can start to grow. So getting back to inherited genes, so these genetic panels of 25 to 40 genes greatly expanded our diagnostic options for hereditary cancers, but it also created new questions. When these genes were identified, we really didn't know, are all of these very important for cancers in families? Which ones should we prioritize? Which mutations are really important? Do we have to get concerned about every one of them? And it created a lot of problems for the doctors and a lot of anxiety for patients. And then what do we do about it? Suppose you do find a mutation that we feel is important. Increased screening and prophylactic surgeries are major steps, but are those our only options? So in this February, studies came out in the New England Journal of Medicine that addressed this. There were two large studies covering about 35 genes, and they sequenced 64,000 women in the US. The other study was over 110,000 women in Great Britain. And these provided a much better understanding of what are the risks across these 25 to 40 genes. It really narrowed it down to about 5 to 8 genes is the most important for breast cancer risk. BRCA1 and BRCA2 remain the top genes in terms of the amount of risk that they confer. And the risk, as you can see by the pink arrow, starts really in the late 20s for women. The dashed line that is lower than the solid line is the average risk for women in the US. Other genes like ATM, CHEK2, and PALB2 show a little bit later start of the risk, close to age 40. So you see there's a difference in age of onset. Also, the amount of risk is a little bit lower, with CHEK2 being kind of the lowest impact of these 5 genes. You can see the height of the solid line in CHEK2 is less than with BRCA1 or BRCA2. And these also relate to what these genes are doing in the cells. BRCA1, BRCA2, and PALB2 help repair DNA damage to prevent cancers from forming. Whereas ATM and CHEK2 are sensing for DNA damage. They still play an important role, but they have a different function in the cell. Clinical trials have looked at what do we offer these patients if a cancer has already developed, because in that case, prophylactic surgery is not going to be possible. The cancer's already there, and if it is metastasized, we need to have some drug treatments for it. So a drug called Olaparib, or Lynparza, has been shown in clinical trials to be effective in treating metastatic breast cancer and also ovarian cancer from BRCA1 and BRCA2, and recently also with mutations in PALB2. The first clinical trial shown here was reported in June of 2017, and then a more recent trial came out in October of this past October, showing the value of Olaparib for these gene mutations. So we now can offer more options to patients depending on where they are. Let me switch now to the not inherited mutations. So these are somatic mutations. These are just in the cancer cells, as I mentioned before. There are many types of somatic mutations. Some examples. So genes that are turned on in cancers are frequently categorized as oncogenes. Oncogene meaning a cancer-causing gene. Genes turned off in cancer could be called a tumor suppressor gene because their normal function when they're on is to suppress growth of cancers. So how do we identify somatic mutations in individual patients? Well, like I said, these mutations are just in the cancer cell. So the most easy way to do that is direct sequencing of the cancer's DNA. But the challenge is that requires a biopsy or a surgical sample of the cancer. And that may not be feasible in all cases or from all patients. Further, cancers can evolve or change over time, and repeat biopsies are usually difficult for patients. So what other options do we have? Over the last 5 to 10 years, we've been found that we can do sequencing of these somatic mutations from blood samples because many cancers will release DNA into the patient's bloodstream. This sequencing has very high sensitivity. It's not 100%, but it has quite good sensitivity because these DNA is in the circulation, and we call it circulating tumor DNA. ctDNA or cell-free DNA, cfDNA. It's more colloquially being called a liquid biopsy. And that is a term that you could mention to your doctor, and most doctors will have heard that term. So by doing a liquid biopsy, We can take a sample of a patient's blood by routine stick in the arm, and we are able to find small amounts of cancer DNA in that, which can then be sequenced. And that can provide some very useful information. I'm going to give you two examples of two genes that we look for in breast cancer. So one gene is called PIK3CA. It's one of the most common somatic mutations in breast cancer. It's found in 40% of ER-positive breast cancers. And there's a drug that we can use to treat this changes in this gene called Alpelisib, or Piqray is the brand name of it. Another gene that I'm going to talk about is HER2, and it's the area of my research. HER2 is frequently talked about when cancers are first being diagnosed, but there are mutations in HER2 that can be found in cancers that are called HER2 negative on routine pathology testing. There are 8 FDA-approved drugs that block HER2, and we've done research to show that these drugs can be helpful for these HER2 mutations. So this is the clinical trial data on Alpelisib for that PIK3CA mutated breast cancer. What you're seeing here in the blue curve is, on average, adding Alpelisib controlled the patient's cancer for 5 months longer than hormonal therapy alone. And on average, it added 8 months to a patient's survival. In May of 2019, the Food and Drug Administration approved Alpelisib in combination with a hormonal therapy drug, fulvestrant, for postmenopausal women with PIK3CA mutated metastatic breast cancer. And the FDA also approved a test to go along with the drug to find these PIK3CA mutations. This test can be done on circulating tumor DNA from a blood sample, plasma, on patients. And the FDA said that if the blood sample, the plasma sample, is negative, does not show a mutation, then consider testing the tumor directly if possible. This is our research on HER2 somatic mutations. 25 patients indicated by these blue circles were found to have HER2 mutations in their breast cancer in this study. And nearly all of these patients were called HER2 negative by routine testing. We hypothesized that patients with HER2 mutations will benefit from anti-HER2 drugs, and that's what we set out to show in our research. So we did a lot of studies in the laboratory to back this up, and then in 2013 we started the MUTE-HER clinical trial, which is a phase 2 trial of an oral HER2 inhibitor for HER2 mutated metastatic breast cancer. MBC stands for metastatic breast cancer here. And so the patients had to have metastatic breast cancer. And we kept the trial pretty open in terms of who could enroll. There was no limits on how many prior treatments the patients could have. They underwent sequencing to find out if they had a HER2 mutation in their breast cancer. If they did, they received the oral HER2 inhibitor neratinib, which is a very effective drug. And they continued on it for as long as their cancer was kept under control, no sign of cancer progression, and as long as they tolerated the drug. The first 16 patients on this trial received neratinib on its own, and then the trial was expanded to combine neratinib with an anti-estrogen drug, fulvestrant. This trial went nationwide. We started with 4 sites, but then expanded out to 15, including 1 site in Toronto, Canada. And we enrolled 56 patients with HER2 mutated metastatic breast cancer. This slide here, which is a little busy, shows you the results on this trial. The length of these horizontal bars is the length of time that the patients were on treatment with the drug neratinib. If they were on it for 24 weeks or longer, which is basically 6 months, we consider that a successful outcome. Also, we were looking if the patient's tumor shrunk, and that's what's color-coded by some of these bars here. I won't take you through all of it, but you can see about a third of patients had a very clear benefit from neratinib on this trial, which is pretty impressive considering many of them had had 3 or 4 prior treatments for metastatic breast cancer and would have required IV chemotherapy had we not had this simple oral option for them. So this was quite a good result. We can use the liquid biopsy to follow if the patients are responding or if their cancer might start to regrow. What we found here in this individual patient's case was at time of starting on the trial, they had a single HER2 mutation, this L869R mutation indicated in yellow. It was detectable at 7.5% level on their blood sample. They responded to neratinib, and the amount of that mutation decreased, as you can see, at the 4-week time point. But 32 weeks later, when their cancer regrew, the yellow mutation had again increased in the amount that we could detect in the blood. But 2 other HER2 somatic mutations had popped up as well, and these are directly related to drug resistance. And so we can use this to track why patients' cancer starts to come back. Are there other things that we can do for it based on this information? Should we change the drugs that we're using for the patient? So this provides a lot of good information for us. And this idea of treating HER2 mutations and using liquid biopsies, circulating tumor DNA, was picked up in a British trial run by Professor Nicholas Turner and colleagues and published in September in the British journal, The Lancet. And in this trial, which they call plasma match, plasma for the ctDNA sequencing that they used, they identified a variety of mutations in the patient's cancer and tried to match them to a specific therapy for that mutation. And you can see here, one of the arms of their trials was for HER2 mutations. And that arm was successful, with 45% of patients benefiting from the neratinib therapy that they got started on this trial. So these are examples of how this is going internationally as a strategy for treating breast cancer patients. And this is work that was started here at Washington University and at Barnes-Jewish Hospital. Also, our leukemia group, the leukemia research team here, is making many, many advances in cancer genome sequencing. And they have this paper that came out in March of this year, looking at genomic sequencing as an alternative to a traditional analysis of leukemias. And they can do this sequencing in an average time of just 5 days and provide more detailed information than can be done with the traditional form of diagnosis for acute myeloid leukemia and myelodysplastic syndrome. And we're now looking at, can we apply this strategy to breast cancer patients and to other cancers too? So there's a lot of developments in the field. It's a fast-moving area. The information on inherited genes in breast cancer is very well developed, and there's a great group called FORCE, Facing Our Risk of Cancer Empowered, that has a very nice website that I would direct you to if you're worried about inherited genes that could contribute to breast cancer or ovarian cancer or other cancers. Information on the non-inherited genes, the somatic mutations, is still evolving and is an area of very active research. So I thank you for your attention, and we're going to take questions now.
Thank you, Dr. Bose, and thank you to everybody asking questions. Dr. Bose, our first question is, how important is it to have a mammogram done after the age of 77?
Sure, that's a question we get that we get asked a lot. And I would say that if you're in good health, that it is very helpful to get a mammogram even at age 77 or older. There's a couple of reasons for that. If a cancer is caught early, it's easier to treat. The treatments are simpler for the patient. Also, there's ongoing clinical trials to look at whether older patients can safely avoid treatments that are used standardly for younger patients, such as radiation. So if you're in good health, I would encourage you still to get a mammogram at age 77 or above.
Thank you. Our next question is, are there any other ways we can detect if there is cancer growing other than the mammogram?
So our two main screening methods are mammograms and a physical exam, either a health professional feeling the breast or the patient themselves feeling the breast for a lump. Breast MRIs are used only in specific circumstances, but in families where there is a known BRCA1 or BRCA2 mutation, that's a very well-established place where we would use a breast MRI in addition to a mammogram to try to detect a cancer. Other uses of breast MRIs are more specific. Breast ultrasound also is a more specific role. There are groups that are doing research to see if blood tests for cancers can be developed. Think of a PSA for prostate cancer. Could you come up with an equivalent one for breast cancer? That's still in the research area, and we will see how that develops over the coming years.
Wonderful. Next question. Can you please speak to the impact COVID-19 has had on your work?
Yes, it's obviously something that we've all been very concerned about this past year or more. In the clinic, about 12 of my patients had COVID-19, primarily over the wintertime with the big wave that we saw here in the Midwest. And one of my patients lost her husband to it. Vaccination is very important, and I encourage you to consider getting vaccinated if you've not already done so. On the research side, we've been cautiously moving forward on our breast cancer research. We've been doing good COVID-19 precautions in the research labs so that we don't have infection spread there, but we've continued forward.
Dr. Bose, at what age would you suggest women get screened for inherited mutations that are known to occur in a family?
It depends a little bit on the circumstances. So in a patient who has been just diagnosed with breast cancer, if they're under age 50, getting screening for genetic mutations is covered by insurance. If it's a triple-negative breast cancer, patients under age 60 can get genetic screening covered by their insurance. If a patient has a strong family history of breast cancer or has a known family member with a mutation, then discussing screening even earlier prior to a breast cancer diagnosis makes sense. And in some of our BRCA1 or BRCA2 families, discussion of breast cancer screening as early as age 25 might be prudent. But those are in families that know they have a BRCA1 or BRCA2 gene mutation. If a person has a known CHEK2 or PALB2 mutation, we can probably wait a little bit later for their family members to get screened because there the risk doesn't seem to start until closer to age 40. But those are kind of the categories and the ages at which this should be considered.
Thank you, Dr. Bose. Should the liquid biopsy only be done once a mammogram is suspicious, or can a gynecologist or primary care physician order one routinely?
It's not ordered routinely yet. It's primarily being used right now in the setting of metastatic breast cancer in order to help us choose a drug therapy or monitor response to a drug therapy. There's ongoing research to see if we can make use of it earlier. Can you use liquid biopsy to detect for cancer coming back? Say in the example of someone who had a stage 1 or stage 2 breast cancer that has had surgery, had the cancer fully removed, and to see is there any sign of the cancer coming back. Stage 1 breast cancer, I should explain, is a small breast cancer that does not involve lymph nodes. A stage 2 breast cancer might be slightly larger or be lymph node positive. So in those situations, liquid biopsies are being studied. And there's a lot of interest in this. There's a lot going forward. And support of cancer research really helps in that regard.
Thank you. If a donor gave you $1 million, how would you use it?
Great question. I think that one great area of need that I've noticed is when breast cancer spreads to the brain. Brain metastases from breast cancer can be devastating. And while we have radiation and in some cases neurosurgery options for the patients, we need to be able to do much more. We're thinking about specific ways. We're wanting to examine this in the laboratory, look at the genes involved in breast cancer spreading to the brain. We know that HER2, both HER2 positive as well as HER2 mutations, are important in this. And that's an area that we are planning to explore more, and philanthropic support would really help us.
Thank you. Dr. Bose, do you recommend mammograms annually for all women, regardless of age?
I think mammograms are very important. I know there's been a lot of controversy. You'll see stories in the news when new studies come out or when national organizations update their guidelines. There's a lot of back and forth about should you start mammograms at age 40 versus age 50 in an average risk woman. And by average risk, I mean someone who does not have a family history of breast cancer. And that's going to be an area that there's going to be continued medical debate on. I think that mammograms, even before age 40, should be considered in families that have a strong family history of breast cancer. And so talk with a gynecologist or talk with a breast surgeon if there's concerns. Those are people who would have more information about that for you.
Thank you, Dr. Bose. And this is a reminder to everybody, if you have any questions, please put them in the chat box to the right of your screen. Dr. Bose, in the future, will people automatically get liquid biopsies for somatic mutations with their regular annual checkups with their primary care physicians?
People are dreaming about that, and right now, it's being explored in clinical trials. It's being explored by companies that are in the medical sphere. But this is nothing standard as of yet. It really has to be of proven benefit. The technology is there, and it's conceivable that could be done. But also the flip side of it is, could we end up overdiagnosing? Could we end up finding things that have really no impact on the patient's health, but just show up in a blood test? So that's the line that we kind of have to walk. Are we doing something that is improving people's health, solving problems, or are we doing something that is just raising things, giving uncertain test results that we don't know what to do with, and provoking patient anxiety? We want to do the former. We want to improve patients' health and not just the latter, not just give them something to worry about.
Thank you. What impact on morbidity and mortality have you seen as the result of advanced diagnosis and treatment?
There's been tremendous advances over the last 10 to 20 years in terms of breast cancer treatment. We've seen that for metastatic breast cancer, where many, many options have become available. In my own area, focusing on HER2-positive breast cancers, we've seen the life expectancy of patients with metastatic HER2-positive breast cancer increase dramatically. Many of those patients are now living beyond 10 years. With ER-positive breast cancer, many additional options have become available in the last 10 years that are lengthening patients' lives. Triple-negative breast cancer, the third major category, we're seeing a lot of advances, particularly in the area of immunotherapy and BRCA1, BRCA2 associated cancers. Both of those categories we're seeing substantial advances. In newly diagnosed breast cancer, there's a lot of options that we can provide to patients, and the combination of treatments after surgery to prevent cancers from coming back, as well as improvements in screening such as digital mammograms, breast MRIs, all of those have improved patient outcomes dramatically. In fact, when you look at the age-adjusted risk of breast cancer and breast cancer death, we've seen that steadily come down from the early 90s because of all of these medical advances.
Thank you. Dr. Bose, are you or your colleagues doing any research around dormant breast cancer cells that live in the bone?
That's not a question I'm directly addressing, but one of my colleagues here at Washington University School of Medicine is very interested in bone metastases, Dr. Catherine Weilbacher, and that's the focus of her research. There are other people nationwide that are looking at dormancy as a factor in breast cancer, and I've heard many talks about them, looking at why cancer cells may be dormant, what causes them to start to grow again. A big question is, are there factors in the are there factors in the bone tissue, in the environment around the bone that helps stimulate or support the breast cancer cells, protect them, let them live on these circumstances? So there's a lot going on there. Dr. Weilbacher has been looking at a drug called denosumab, brand name Xgeva, as a method to block some of the pathways that keep breast cancer cells alive in the bone. And so that's an area of very active investigation.
Thank you. Is mastectomy the most effective method to prevent cancer in patients with BRCA genes and close family members with breast cancer?
So certainly mastectomy is very commonly used, and prophylactic mastectomy is highly, highly effective in preventing breast cancer occurrence in these families. Of course, if it is a young woman that we're talking about, we certainly want to be sensitive to that person's desires for children, for breastfeeding, and want to make decisions appropriately for that. It's easiest once that person has said, okay, I'm done having my children, now I really want to think about reducing my breast cancer risk, and prophylactic mastectomy, removal of both breasts, would be something that we would strongly discuss with a patient. Also, ovarian cancer risk has to be considered in BRCA1 and BRCA2 families, so that also may be something for prophylactic surgery. So those steps are a good way to prevent cancer from developing in those families. If someone is not ready for those surgeries, then increased screening is a good option. So a family member who in a BRCA1 or BRCA2 family could reasonably say, I'd like to do breast MRIs for a few years before I get to the point where I'm ready to do surgery, or do pelvic ultrasounds to check the ovaries before I get to the point where I'm ready to do surgery to address ovarian cancer risk. So those are very reasonable options for those people.
Thank you, Dr. Bose. We have 2 more questions. Can your sons inherit cancer from a mother who has had breast cancer?
Yes, that can occur. So most male breast cancers tend to happen at a later age than women's breast cancers. I've seen it more in men in their 60s and older. But men do have a rudimentary breast tissue, so men can develop breast cancer. It's really 1% or less than the rate of women, but it's something for men in BRCA1 and BRCA2 families or other inherited gene families to be aware of. Self-exams is something to consider, or talking with a breast cancer specialist. Another important thing is that men can pass on the gene. So we will see cases where a young woman comes to us and says, I've just been diagnosed with breast cancer. My father's mother, my paternal grandmother, had breast cancer at a young age. And we investigate that because their father could have passed on the gene to them and not have developed breast cancer himself. So that's another important way for us to think about breast cancer in men. And it may be reasonable for a man with a breast cancer history in his family to get screened by these genetic tests if he's worried about the risk to his daughters.
Thank you, Dr. Bose. Thank you, everyone, for your questions today, and thank you, Dr. Bose, for your time. Our last question is, thank you for your presentation. What is something cutting edge you are excited about in your field?
So there's many things that I'm excited about. The ability to sequence genes in cancers and in patients really opens up a lot of revolutions in the field, and we're applying that to individual patients now. In terms of clinical trials for metastatic breast cancer, studies looking at patients who've been diagnosed with breast cancer recently, genetic testing options for patients. So these are really important things. We can take this further, and we thank you for your philanthropic support. We thank you for your interest. If you've been touched personally, consider clinical trials as ways to help advance the field. There's a lot going on, and there's a lot of advances that we are making and that we're tremendously excited about.
Thank you, Dr. Bose, and to those of you who asked questions. This presentation was fascinating, inspiring, and informative. Dr. Bose, thank you for your perseverance and dedication that has led to such remarkable progress for breast cancer patients everywhere. You're bringing more hope to so many. We're honored to be able to share this positive news with our Legacy Circle members. As we go forward, donor support will continue to play a key role in advancing breakthroughs in breast cancer and many other diseases. Our researchers rely on the generosity of our donors to help more of our families and friends. Thank you all for joining us for this virtual Legacy Circle celebration and for your trusted partnership. It's always an honor to recognize you for the incredible legacy you're creating for generations to come through your gifts. We're forever grateful, and your generosity and commitment that inspires researchers like Dr. Bose every day to do more. If you have any questions about Barnes-Jewish Hospital, any of our partners, or about your gift to the foundation, please feel free to contact us at any time. A special thank you to Joan Cheney with the foundation team as well. Many of you know and work closely with Joan, and we appreciate all that she does. Lastly, thank you to Susan L. and the Foundation event team for putting this virtual celebration together. Thank you again for joining us. Have a wonderful afternoon, and I hope to see you soon.